Hi, guys. I usually struggle with podiums because I don't know if I'm going to be hidden by this large kind of thing, so I'm quite happy, and I also struggle with technology, so bear with me. I wanted to add that thank you to the brilliant panel, because you've done most of the work for me. This is the best thing about coming last, because you can just build on what everyone else has said so brilliantly, so thank you for that. You know, Sally, it was really great to hear you talk about Hillary and our relationship, because basically research and partnerships and when we're in institutions, it's really the trust and the long-term kind of friendships and a commitment to equity and doing meaningful work is what you build, and LSTM really reflects that. So I just wanted to talk a little bit about what do these presentations mean, but what does research mean, yeah, for all of us? So I'm going to have a go at this technology. So we heard from many of these stories that people lead very precarious lives. And if you look at communities, these are sort of people, they're not faceless beings, they're not numbers, these are people who are struggling, who are suffering, but they're also very pragmatic. They are smart. They figure out resources, they figure out networks, and they make things happen in the absence of very few choices. So this picture is of, hang on, let me just, can you see the picture? Yeah, okay. It's taken of, a slum, a corner of a slum, but this kind of picture could be captured anywhere, and many, many countries around the world, because now we have about 5 million in Dhaka city, that's the capital. You've got by 2050, about 7 out of 10 will be living in cities, and mainly in informal settlements. Informal settlements, as Bachara and many of my speakers explained, live very sort of informal lives in the sense they're not recognized. So we also have, I'm trying to figure this out, so bear with me. So you can see the skyscrapers at the back, you can see the slums. This is everyday life in many cities. And I don't think it's unusual. When I was in New York many years ago, I was shocked when I went down the wrong subway and got lost because I was trying to figure out my routes, that I ended up in an inner city underbelly of a very poor area, which was completely different to Manhattan. There were no parks, there were no street lights, there were many more police. It's just the reality of global worlds and cities that we live in. An underbelly, and then we've got many of us who live privileged lives. So we do have a crisis. Everyone in the last few days talked about a crisis. I don't want to make it all about doom and gloom, but I do think we are facing real challenges. We've got, by 2050, it's estimated that between 25 million to 1 billion will be displaced. Humanitarian, climate affected. You've got an ongoing genocide. You've got war and conflict. You've got emerging infectious diseases. You've got inflation. You've got humanitarian crisis. You've got refugees. Against this backdrop, we've also got growing intolerance, shrinking civic space. But we also have a lot of committed individuals in this room and beyond this room that want to make a difference. So these are women. These are women that I work with and have been working with for 2 years. I've known some of them since 2006. They were street children. What they have is intergenerational poverty. Their mothers sold on the streets. They sell on the streets. They have children. They get married early. Bangladesh, I think we're the 8th highest in early marriage. Globally, 12 million young adolescent girls are married by the age of 18, often 15 to 16. They're pragmatic, they're smart. This is not of their own choice. They're surrounded by factors that leave them of no control. People around them are getting married. They're expected to get married. They have children early. They sell on the streets. And often, when you are an informal worker, you don't have social insurance or stipends or labor laws that regulate. So 2 billion people work in the informal economy, which means 60% are employed in this in the sub-Saharan Africa, South Asia. So 9 out of 10 workers are part of an informal economy. They make sure things run in many of the households. They may be maids, they may pull the rickshaws, they drive the buses, they run the shops. They might be informal workers in many, many cities. So these young people are weaving in and out of traffic. This is Gulshan. Gulshan is a richer area. So at any given time, if you visit Dhaka, you will see it in many cities. They're weaving in and out of traffic, trying to sell towels, toys, calendars, flowers, and they make money based on that, on the kindness of strangers. So one thing I wanted to say was we have multiple frameworks to understand syndemics, social determinants of health, intersectionality, critical medical anthropology, ecological theory, political economy. But the reality is social sciences remains on the periphery. And I think what I find very exciting about this conference is the inclusion of this panel. It's unusual. And I think credit goes to David and many others, Sally, and the panel to say, look, we matter, we count. And it's not to demonize disease-centric approaches. It's really to say, as Laura put it so beautifully, how do we work together? How do we have shared language, given our values and our goals are to make a difference? So contexts matter. When we're talking about someone seeking healthcare, be it an informal provider, be it a service, be it down the street, this is what they're grappling with: congestion, waste, erratic water supply, disease, infections, crowding, congestion. This is everyday reality. Lining up for water, often you have to pay local powerful actors in slums. This is the case in many slums. When I went to Nairobi, when I went to Sierra Leone, it's no different. You have power brokers everywhere. I'm sure in Liverpool there's different power brokers in the impoverished areas. It's just human nature and the power of politics and privilege. So unpacking health, I'm going to give you quick 2 stories. This is Mina. She was a maid, and before COVID, she went to Jordan to try her luck earning money. It didn't work out. She came back. For many of Bangladeshis, including myself, but many of the ones who are less well off, these unlicensed pharmacies are the first resort to care. So 80% go to local pharmacists. On the other hand, it's this dilemma, because I live in Bangladesh where we have a national drug policy, which means medicines are cheap, which is very important from an equity perspective. At the same time, we have looming AMR concerns because of irrational drug use. This is the complexity and messiness of life, really. So they can go to any drug seller, not wait 2 hours in a clinic, not pay a broker to access, not have to deal with hidden costs. A pharmacist will give you a waiver in fees. A pharmacist will give you the medicines and say, you can pay me in 3 months because you know them really well. A pharmacist who's unlicensed, untrained, becomes a family member to guide you. This is the reality of health systems in many places. It's not about clinics and facilities, it's about trust and building relationships. So Mina became a maid, lost her job post-COVID. Her husband has TB. 2024, they can't share he has TB. It's still considered a contagious and deadly disease. So they hide that. They take treatment from the pharmacy. They take treatment when they can, but there are costs. She manages the household because he doesn't work. She has kids. Her daughter she pulled out of school to work in a garment factory. Here we have a cycle of intergenerational poverty because she said, I wanted her to study. I don't want her to have my life. I don't want her to get married. But we don't have options. Post-COVID, there was widening inequalities. Ukraine war meant prices from gas, fuel, to even food prices. I don't know the connections, but these are the connections that are happening. Then you have Fatima. Fatima basically has set up a bank account. This is a big deal. She lives in a slum. You saw pictures of the slums. Her brother and her family support her. She was 8 months pregnant. She was still selling on the streets because her husband had erratic income employment opportunities. You have to remember, many who migrate or live in Dhaka city or who are chronically marginalized don't have the education or the skills. Plus, you need networks to access. It reminds me of when you get a job through references in many institutions. But if you're very vulnerable, you don't actually have access. So Fatima worked and worked, selling on the streets in the hot sun towels to make ends meet. She ended up having a cesarean. Do you know that in Bangladesh, cesarean is 45%. It's higher than the 10-15% that is recommended by WHO. That is overt biomedicalization, that's a profit-making industry, and many are part of this. And we don't have good communications. In fact, people are incentivized to get cesareans done. So if you look at Fatima and Mina, and many of the stories are shared by others, their health causes are much deeper. They're structural as much as they're biological. And I think we need to understand, and I think you do. I feel we're talking to a converted audience, or maybe I'm just optimistic, but it's really much deeper than just having a disease inside the body. So then what are the core principles that guide global health research, should guide us? And I think I'm just going to be repeating some of the earlier statements, but really there is a language, and power around language is very, very important because it leaves out certain kinds of categories or disciplines, or it includes certain categories and disciplines. There's a knowledge hierarchy. And right now, the knowledge hierarchy is very much about a biocentric, biomedical, disease-centric approach to global health. And that also informs much of the research in South Asia. That doesn't mean that, I don't want to demonize disease-centric research. I saw the last few days the work that's being done, the innovations, the solutions, the commitment, the ethical and moral responsibility researchers have taken on board. But I do think it's important for global health to increasingly recognize the personal, the social, the cultural determinants of health. During the Ebola crisis, I have a colleague who teaches, and she said one of the key reasons why people didn't want to share their symptoms was they were worried about burial rites. Something simple as spiritual, religious, emotional reasons impact on how people behave. In Bangladesh during COVID, people did not want to report to community health workers when they had COVID symptoms. They were worried about burial rites. They were worried as Muslims, they were not properly buried, they would not go to the afterlife. These are deeply personal factors, but very important factors. Another quick example is the way gender is understood. Gender often equals women. This is in social sciences, but in many other disciplines. This is problematic in many ways, because if you look at class and poverty and ethnicity and categories of caste, we tend to essentialize and universalize experiences and standardize groups. And I think we need to really understand history and politics and how people are located and produced. So ultimately, we need to move away from a particular dominance. And as I said, this conference and the fact that you have an entire panel dedicated to this means there is a lot of commitment to bringing together different disciplines, from anthropology, and I'm hoping economics as we move forward, ethics, history, political science, to work together. But the reality is a lot of donor funding, and agencies still prefer RCTs, or lab-based, or clinical. They're considered the gold standards. So the idea is to kind of push back and say, there are many different kinds of knowledge. Can we unpack what counts as evidence? Can we take that moral authority to challenge what is evidence and the politics of evidence? Can we also share that this particular methodology brings in this evidence, but it also has certain biases and limitations? And we need other players so that we don't work in silos. And I think that's very important. I'm a little bit behind, as you can see. But I call it the fault in our methods. And I will still say there's a fault in our methods. And I think we need to recognize that in global health, in the work I do, in the work we do. We need for humans to flourish. And I think there's obviously a lot of commitment. Otherwise, you wouldn't have this conference, but also many of the conferences I go to, there's a real sort of driving need to understand, how do we improve? How do we work better? What are our limitations? What are the challenges? But I think this is also a good time to shift and push against the framing of global health, to push for more inclusive research approaches, to actually acknowledge diversity and push funders. We have people in this room who have good relationships and networks with funding bodies. I'm looking at you, Sally, you're at FCTO. But I also think it's really important to kind of look at the way we can actually change or enable, I don't know about change, enable, in small ways, improve the lives of the most marginalized. So, finally, what are our fundamental values? Where people are born, how they live, how they work, fall sick, how they die are affected by the environments they live in. We must ask ourselves again, what is the value we place on human life? And this requires an interrogation of our own politics, our privilege, our power, to make changes, the research we do, for in policy, the different disciplines, the roles we play. I think our own individual and collective values are critically important at a time like this. We also need a firm commitment to acknowledge and tackle the underlying root causes of bad health. While that might be a larger task than what we've signed up for, I think there's small steps you can take. The way we do research, Arise was shared. Many other examples were given in the last few days. There are small steps we can take when we work together with communities and engage with key stakeholders. Finally, the future, what are we leaving behind? So I end on a hopeful note because I'm here at this conference and I see an interest and I also see a lot of work, and maybe I'm biased, I've been working with Sally for 20 years, but there is a strong social science sort of network and presence at LSTM. There are efforts to be inclusive. I mean, I credit Sally and Miriam and Rachel and Laura and Rosie and Rossi and Shireen, but a lot of colleagues, you know, Marcy, I mean, many people I've been working with who are committed to social science. And I see this in this platform, and I know that David's been extremely supportive, and I've heard that from Sally, and I know that you are open and interested in being very inclusive, but how do we reach global health sort of targets and goals? I also think when I spend time in this conference and I see the partners like Bintu and Abu and even my own colleagues and the early career researchers and the PhD students and the postdocs, there's a real kind of commitment to partnership, equitable, meaningful partnerships. I also see clinicians and people who work in labs in the same room. Sometimes that's rare. In the countries I come from, where you have economists and clinicians, and us in social science are often continue to be in the periphery. It's nice to see this in this conference, and it's nice to see this being celebrated. So I would say that LSTM, whether you recognize it or not, you are ahead of the curve. I've been working in research, and we bring in our own funds for about 25 years. And this is one of the few institutions where I've actually seen action and implementation and ways of working around and creating these partnerships and creating and building a next generation public health leaders. I'm not saying this because they paid for my trip to come here, but I'm expecting maybe extra lunch. But I really mean it. I've said this in one of our board meetings, that I don't think LSTM recognizes how much they've actually achieved and how much work is being done. So I just want to congratulate the school, but all the faculty and all the colleagues and staff. And I think you're ahead of the curve, but this requires sustained investment and support. And I hope you don't lose momentum. So congratulations, and it's been a pleasure and an honor to speak today. Thank you.
thanks so much, Sabina, for providing us with your wealth of insights and challenging us as an institution. And I think the challenge we have is to keep talking to each other, keep working across these disciplinary boundaries. Together we are greater. We heard that from everyone. The challenge is there. We want to, we've got our own values at LSTM. And we've got our focus on equity. We've got our goals, the health systems goals, the SDGs that we're trying to move towards, and that requires collaboration. So we've had a strong call from our panel and from our keynote to discuss, to build linkages across disciplines.